Good evening, everyone. I'm Molly O'Brien with the Association of Migraine Disorders, and thank you so much for joining our first webinar on migraine and pregnancy. We have a series of 3, and we're really excited to bring forth some very good information for you. So before we get started, we're just going to let people kind of trickle in, and I just want to say hello and welcome to all of you for the Association of Migraine Disorders first webinar in our series of 3 on migraine and pregnancy. We're going to be talking about a bunch of different topics over the course of the next 3 weeks, and we're super excited to kick off this first webinar. Again, my name is Molly O'Brien, and thank you so much for joining us tonight for the Association of Migraine Disorders Migraine and Pregnancy webinar series. So throughout the month of May, we have 3 webinars that focus on migraine during the stages of pregnancy. And tonight we will discuss preconception, in vitro fertilization, otherwise known as IVF, and migraine disease. Next Wednesday at 7 p.m., that's Eastern Standard Time, we will have a webinar on migraine during pregnancy, and that includes treatments, common pregnancy concerns, and other comorbidities. And then our last webinar in this series is on May 25th at 7 p.m., again, Eastern Standard Time. And we'll have a webinar on migraine during the postpartum phase. Our speakers in that webinar will discuss medication use during the postpartum phase, including while breastfeeding. And we'll talk about other strategies for being a new parent with migraine. If you did not already register for those webinars, we will have a link in the chat box so you can do so, because we would love to have you join us. So I think we are going to get started here in just a moment, still letting people filter in. But again, hello and welcome. My name is Molly O'Brien with the Association of Migraine Disorders, and we're very excited to have you for our first webinar on conception, preconception, and IVF and migraine. So to those of you who have not been able to conceive, we just want you to know we see you, we recognize you, and we support you. To those of you trying to conceive and those of you who are thinking about pregnancy, we hope this webinar provides some insight on the relationship between migraine, infertility, and IVF. We hope all of you walk away with the knowledge on the relationship between migraine and pregnancy and how to plan for pregnancy while dealing with migraine disease. So AMD will also be posting resources on the migraine pregnancy connection on our website at migrainedisorders.org. We'll put the link to that in the chat box as well. So if you want more information, you can head over to our website. And also, please feel free to use the chat function, which I have already talked about several times, so you can communicate with one another. Feel free to share stories and all of that. We would love to have you build your community here. That's one of the reasons why we're doing this. So we will also have a question and answer period at the end of the presentations, and we hope that you can put your questions in the Q&A box. Please don't put them in the chat box. We want to make sure we get to them and we see them. Okay, so again, as people are joining in, I'd like to introduce our speakers and give you a heads up on them before we get started. So our first speaker will be Alicia Wolf. She is a vestibular migraine advocate, owner of the dizzycook.com, and the author of the best-selling cookbook, The Dizzy Cook, Managing Migraine with More Than 90 Comforting Recipes and Lifestyle Tips. And then we will hear from Dr. Addie Peretz. Dr. Peretz is a clinical assistant professor of neurology at Stanford University, and she's a board-certified neurologist with a subspecialty certification in headache medicine. She is passionate about providing comprehensive headache care for women, especially during pregnancy and postpartum. And it looks like our other speaker has joined us as well, Dr. Alex Polotsky. Dr. Polotsky is the medical director of Shady Grove Fertility in Colorado. He's also the reproductive endocrinology He's also the Reproductive Endocrinology and Infertility Fellowship Director at the University of Colorado. Dr. Polotsky is board certified in obstetrics and gynecology, as well as reproductive endocrinology and infertility. So thank you all to our speakers for joining us. We really are looking forward to your presentations. So after our speakers, we'll hold a 15-minute Q&A period. So please put your questions again in the Q&A feature so we can get them. And again, feel free to comment amongst each other in the chat function. And please be aware that our speakers cannot answer personal medical questions. Please note this webinar is this webinar is intended for general informational purposes only and does not constitute professional medical advice, diagnosis, or treatment. Always seek the advice of a physician or other qualified health provider with any questions you may have regarding a medical condition. The speakers do not recommend or endorse any specific course of treatment, products, procedures, opinions, or other information that may be mentioned. Reliance on any information provided by this webinar is solely at your own risk. So now that we have the agenda, we have the disclaimer out there, let's get started. There's a wealth of information that we're going to share with you today. We're so excited to do so. So with that, I'm going to turn it over to our first speaker, Alicia Wolf.
Alicia, I think you may be muted. Does anyone else?
Thank you. Of course. Thank you so much for having me. I'm really excited to be here and to be talking about this. This is something I'm very passionate about, and I'm just really thankful that Association of Migraine Disorders has taken this on as a platform, because when I was going through it, I felt like I had no resources and I couldn't really get a lot of answers from my physicians about what to expect when it came to infertility and managing migraine. Of course, setting out on your own fertility journey can be quite a scary process when you also are dealing with a chronic illness like migraine. And for me, specifically vestibular migraine, I had heard from many doctors that some patients got better, some patients stayed the same, and some patients got worse, but you never quite know which one you'll be in. So it's kind of a guessing game, and that doesn't give you a lot of peace as you set out on having children, which is also a scary event in your life. Can be wonderful and rewarding, but also a little terrifying to change your lifestyle like that. And so about when I was considering getting pregnant and we were finally thinking about getting ready and starting to talk about this, was when I got hit with chronic vestibular migraine. Took me about 7 months to get a diagnosis, and I had unexplained dizziness, vertigo episodes. I felt like I was moving when I was standing still. And I just remember thinking to myself, there is no way I can have children with this kind of disorder. I mean, what's going to happen? This is going to change our lives. And eventually I found a really, really good neurologist who got me on a great treatment plan. And I slowly started to improve, and I went from chronic to episodic and even into remission for a little while. So before I started my fertility journey, I really considered myself in remission. I still had to work at my migraine treatment every day, but I was no longer having attacks for weeks at a time, if that. And if I did have dizziness, it would just be slightly increased. So the good part, good, I say, but I guess serendipitous part was that struggling with infertility sort of gave me time to manage my migraine. And I didn't realize that we were even going through infertility for a while, just because I was so focused on improving my migraine. But we eventually started trying as things started to improve. And this was something I worked with my neurologist on, to get on a plan where I could eventually wean off the medications or potentially stay on my medications as I got pregnant. And so that's something that's really good to plan for ahead, and to loop your OB in as well as your neurologist, and even get them to communicate with each other. It can be really helpful. But so I had done that, and I had time to do that going through this. And we had been trying for a little bit over a year when I finally got pregnant. Unfortunately, it was a fairly early loss for me, and it was really, really devastating to go through. But my OB had assured me that, this is pretty common, that 1 in 4 women go through it, and that we'll keep an eye on it, but it's not something to really worry about now. Well, then it took me like another 6 months to get pregnant, and that ended up in another loss. At that time, we did some preliminary testing just to make sure there were no genetic issues, some blood testing, and just to make sure that we covered kind of all the general bases. But she said after 2 losses, she likes to refer to a reproductive endocrinologist. It was at that point I worked with reproductive endocrinologists in Dallas, and they ran even more tests, lots of blood work to see if we could kind of pinpoint what was going on and why it was not only taking me so long to get pregnant, but why I kept having these early losses. And at that time, they really couldn't find anything. I had unexplained fertility, and then they really couldn't find a reason behind the losses. Everything looked fine as far as genetics. My egg quality looked okay. I was kind of on the borderline of some of the blood tests, but nothing that would cause any red flags. So we started a general treatment, and usually what a lot of doctors like to start with is IUIs or timed intercourse. And so that's what we originally started with just doing Clomid and then a trigger shot. Surprisingly, the first month we tried that, I got pregnant, and I thought, okay, this is it. When you go to see a reproductive endocrinologist, they really pay attention to your blood work. So they were monitoring my levels right away whenever I got pregnant. And unfortunately, my levels started out pretty low, and then they started to increase a little bit. And so I had a lot of hope that this was going to work out. But after another few days, they started to decrease again. So this whole process ended in another loss for me, which was pretty devastating. Honestly, Clomid was one of the most difficult medications I took during my experience. It just, I don't know if it was part of getting pregnant and having these losses or if it was the Clomid itself, but I just felt pretty miserable on it after feeling so good for so long. So this, coupled with the heartache and the emotional distress of continuing to go through this, we decided to do another 2 rounds, and then we kind of drew the line at that. And those next 2 rounds, like nothing happened for me. It was then I talked to a vestibular migraine friend. He is actually the chairman for Resolve, which is the National Infertility Association. And we just kind of had a heart to heart one night. And he just said that, the best way to go and to really figure out what was going on was to go through the IVF process. So that's what kind of led me to the IVF process. I did notice that during some of my IVF treatments, actually, egg retrieval was one of the easiest, as well as those. I thought all those medications and shots would be what increased my symptoms, but it was actually during my first trimester, they put you on progesterone and estrogen to kind of support the pregnancy. And that's what I had the most difficulty with. I will say that overall, the infertility process, especially the IVF process, did not bother my head as much as I thought it would, but there was definitely an increase in symptoms. So I would say that having a good plan with your neurologist, having them communicate with your reproductive endocrinologist and your OB is very important. It's also very important to talk to them about stepped protocols. So if this doesn't work, what do we go to next? And just having a plan in place, even before you go down the infertility journey, helped me a lot, because when one thing didn't work, we could switch to the next thing. Now there are a lot more options, and I think that it can be kind of frightening to talk about medications while you're going through this process, but I do have some IVF and vestibular migraine friends who actually stayed on their medications during the process, and they went on to have very healthy and wonderful babies. So I don't think that, I feel like that's something that's that's between you and your doctor and what you're comfortable with. And just don't feel any guilt on that. I hope no one feels guilt on it, because what's right for one person, may be a different path for someone else. But that was basically my story. And I hope that I get to see you guys. If you guys have any more questions, feel free to reach out to me. I talk about this in a little more detail on my blog, thedizzycook.com. I have a whole post on my IVF journey that you can read there as well.
Thank you, Alicia, so much for sharing your story and your very difficult journey. I'm sure that there are many others that are facing a similar type of journey. So we really appreciate you being open and honest and sharing what you have gone through to get where you are today. It really means a lot.
Thank you. Mine had a happy ending, so I hope that other people can look at it and see that, it is possible to get your happy ending. Just sometimes the journey is very difficult.
So true. And we're very excited for you. And again, if you have any questions that you would like to ask, feel free to go ahead and put them in the Q&A box. And you are more than welcome, our attendees, to chat amongst each other and connect in our chat box. So thank you again, Alicia. All right, our next guest, I'd like to turn it over to Dr. Addie Peretz, and she is going to start her presentation. Take it away.
Thank you so much. And first of all, Alicia, thank you for walking us through the journey that you've gone through. And I am so happy for you that there was a great ending to it, but I know that the journey can be a difficult one. Also, thank you to the Association of Migraine Disorders. This is such an important topic, and I'm really, really glad to be able to talk to you about it here today. This is an exciting time as you're thinking about pregnancy, but when you live with migraine, the concept of not being able to take medications that you want to take can be a really daunting one. So I'd love to kind of walk you through some potential options that you can consider bringing up with your headache specialist and obstetrician. So I'll first kind of go over a little bit about migraine and pregnancy and what to expect, and then we'll kind of talk about how to plan for a pregnancy when you live with migraine. Thank you. So in terms of pregnancy's influence on migraine, there's a lot of good news here, and that is that up to 80% of women can experience an improvement in their migraine during pregnancy. This is often for women with migraine without aura, and we tend to see this improvement more towards the second and third trimester, which still means that the first trimester can be a very difficult time, especially in conjunction with morning sickness. And so it's important to be aware of some strategies to help you manage migraine, because you may be likely to experience attacks during the course of pregnancy. It's also important to note that for women with migraine, there is a slightly increased risk for some pregnancy outcomes like preeclampsia. So make sure that your obstetrician is aware of this so that they can monitor you closely for any adverse outcomes that may be coming up. And then one thing that I think is really helpful is I like to see my patients months in advance of them trying to get pregnant. And sometimes that's not always possible. About 50% of pregnancies are unplanned. And so when you are speaking with your headache specialist about different medications, make sure if you are a person of childbearing age, a woman of childbearing age, that you know the safety of medications during pregnancy in case you do get pregnant. But if you are thinking about a pregnancy, it's great to talk with your neurologist ahead of time and to talk about a few different things in particular. One of those is really optimizing the behavioral strategies for helping you to manage migraine. And this is really turning to non-medication strategies that can be very helpful, that have been proven efficacious in managing migraine. You want to also review your current medication strategies and decide which ones are appropriate to continue and which ones need to be discontinued before you're pregnant. And you want to develop a migraine action plan. You want to be solid in what are you going to do when you have a bad headache. And I loved what Alicia said of like, what's my step one? What's my step two if things don't work? And I think it'll provide you with some reassurance if you have a plan in place there. So the next slide, just kind of I'll give you kind of a brief overview of elements of a successful migraine treatment strategy. And there are three main elements, which include behavioral strategies such as maintaining a regular schedule, mindfulness and meditation, some rescue strategies. Some traditional rescue strategies are medications like non-steroidal anti-inflammatory drugs, triptans, acetaminophen, some newer medications to the market, such as Gepants and Dietans. These are medications that you take in the moment when you're having a bad headache. And then there are preventive strategies, which can include some vitamins and minerals. It can include some medications that we often borrow from other fields, such as antidepressants or anti-blood pressure or anti-seizure medications, along with some newer medications to the market, like onabotulinum toxin A, and these medications called CGRP monoclonal antibodies. The point is that there's a lot out there that we can access. But moving on to the next slide, I want to kind of highlight some of the things that we want to be mindful of as you're kind of thinking about a pregnancy. So in the next slide, we'll kind of look at the different, for behavioral strategies, there might be some modifications that you make to the different strategies that you utilize, perhaps during a pregnancy, speaking with your obstetrician about what are exercises that are safe for you to be doing. With rescue medications, you may think about trying some different ones, and we'll kind of go over some options that you might consider. And there also might be some medications to avoid as you're trying to get pregnant that might interfere with that process. And when it comes to preventive medication, you really have to understand which ones are going to be safer in pregnancy, and those that aren't safe in pregnancy, you may have to stop those in advance. In terms of behavioral strategies, just to kind of go over there are some kind of lifestyle strategies that can be helpful. Maintaining a regular schedule can be really beneficial. And migraine attacks tend to be triggered by changes to routine, to schedule, hormonal fluctuations. Some of that is within our control and some of it isn't. But to the extent that you are able to exercise on a regular basis, eat regular meals, get restful sleep, have healthy meals, and stay hydrated, those things can be helpful in making you less prone to having a migraine attack. There are also mind-body strategies such as biofeedback, relaxation, and cognitive behavioral therapy. These things take time to learn and to enact. And so it's great if you have time before pregnancy to be able to learn these techniques well, so you can utilize them even during a pregnancy when you have a migraine attack. And they are well-proven, efficacious strategies that don't have adverse effects for baby. There's also body-based practices, things like acupuncture, although you do need to let the acupuncturist know if you are trying to get pregnant or are pregnant, because there are some sites that can induce labor, as well as physical therapy and yoga, which can be helpful. When it comes to medications, this is an important opportunity to sit down with your headache specialist and your obstetrician and talk about what's the safety of the medications that you're on from a pregnancy perspective. And some medications you will want to consider discontinuing prior to pregnancy for the safety of baby over the course of pregnancy. So in the next slide, we'll kind of focus on rescue strategies first. So in terms of rescue, sorry, you can advance the next slide. So in terms of rescue strategies, one thing that can be really daunting is the idea that you can't take rescue medications as you're trying to get pregnant, because we don't know how long that's going to take. And so this strategy that I'm going to highlight here might allow you a little bit more flexibility. And the strategy involves kind of separating out your cycles. So if you have a regular menstrual cycle, during the first half of the cycle, between when you have your period or you menstruate and ovulation, at that point you shouldn't be pregnant. So you can take most of the rescue medications that you want to be taking. For the second half of the cycle, between ovulation and menstruation, there is a chance that you could get pregnant. And so that might be a time to be more restrictive about the rescue medications you're taking. And hopefully this gives you more flexibility within your menstrual cycle to be able to have medications you can take so you don't feel that you have nothing. And moving on to the next slide, we'll kind of highlight some of the medications that you can that you might want to think about avoiding when it comes to rescue medications. So for opiates and butalbital containing products, these aren't really recommended for frequent headache treatment. And part of the rationale for that is that they can readily cause rebound headaches or medication overuse headache. They also have addiction and abuse potential, so we worry about their frequent use. There are some medications, such as a class of medications called Gepants, lasmiditan, and dihydroergotamine, that are not thought to be safe in pregnancy. Gepants in particular are a medication that block CGRP. the receptor to CGRP. And CGRP has roles in fetal development, and abnormal levels can actually increase the risk for preeclampsia. So for that reason, I have theoretical concerns with being on medications like ubrogepant, rimegepant, and atogepant as you're trying to get pregnant. Also, with nonsteroidal anti-inflammatory drugs, some of these can interfere with embryo implantation. So just be extra cautious. I believe ibuprofen doesn't, but some of the other ones can. So if you're trying to get pregnant, this would be a class of medications to be a little bit more careful about. And then one thing that I find really helpful is to kind of develop a migraine rescue action plan with your obstetrician and your headache specialist and enact it before you get pregnant so you can see if you're comfortable with it and if it works well for you. For me, the first line would be behavioral strategies. What are some non-medicine techniques and tools that you can be using to help with managing the pain? Sometimes that won't be enough and you may need medication. So the second line would be medications such as acetaminophen, metoclopramide, and diphenhydramine. These are thought to be relatively safe in pregnancy. Occipital nerve blocks, which I'll go over in a moment, and neuromodulation devices are really interesting techniques to be able to use both preconception and during pregnancy. When it comes to non-steroidal anti-inflammatory drugs or NSAIDs, again, you want to be careful preconception because it can interfere with embryo implantation. And during pregnancy, there's only a small window of time when it's really okay to be using NSAIDs. You should definitely talk to your obstetrician about when it is safe. And third line, you might think about our traditional triptans, which we use as a migraine rescue often. And that could be a third line option when you're pregnant, ondansetron and promethazine as well. And I know that next week you'll be hearing about migraine in pregnancy, so it'll be really interesting to get their take as well. When it comes to nerve blocks, these are a great option if it is available to you. What it is it's an injection of anesthetic, typically lidocaine, because that's thought to be safer in pregnancy. It's done at the back of the head. It burns as it goes in, and then it causes a sense of numbness that persists for a few hours, but that can give pain reduction or relief for a number of hours to days. And while it's not very, very well studied in pregnancy, this is thought to be a relatively safe option and can be a great option if you're having a bad migraine flare-up and you don't want to take oral medications because it is a local treatment, so unlikely to affect baby. And this is something that I utilize for a lot of my patients who are pregnant if they're interested in trying something to break up a cycle of migraine, but they're afraid about taking medication. And the next slide kind of highlights some of the really interesting neuromodulation devices that are out there. These are tools that could be considered during pregnancy. They're non-invasive, they're not medication. They have been cleared by the FDA for use as migraine rescue or preventive options. To be clear, they have not been studied in pregnancy, but when we think about the mechanism of action of these devices, I'm hard pressed to imagine how it would impact baby directly. These are stimulation devices that stimulate nerves or magnetic stimulation devices. And so these are really reasonable options to think about. The problem with them is oftentimes that they're not covered by insurance. So there is a cost consideration here, but if it is affordable to you, you may want to consider trying this preconception to see if it's something that can work well for you and that you feel comfortable using during a pregnancy. Now I want to shift focus to talk a little bit more about preventive options. So for those individuals who have frequent migraine, you may be on a preventive medication. And some of them are not safe in pregnancy. And so you need to think about how long in advance do I need to stop this medication in order for it to be out of my system as you try to get pregnant. And you should also talk with your headache specialist about whether or not you should replace that with a different medication if your headaches are very frequent. When it comes to oral medications, these usually have a pretty short half-life, which means that they're cleared out of your system over the course of a few days. So once you stop it, a few days later, it should be out of your system. Medications like topiramate, valproic acid, candesartan, lisinopril, and venlafaxine are sometimes used for migraine prevention, topiramate in particular. And because these are not safe in pregnancy, I would strongly recommend tapering off of these medications in order to prepare you for a safe pregnancy. When it comes to injectable medications, such as irenuimab, fremanezumab, galcanezumab, as well as onabotulinum toxin A, These ones have a very long half-life, so they do require months of no use in order to clear them out of your system. I would strongly recommend avoiding iralimumab, fremanezumab, and galcanezumab during pregnancy. I would stop it a number of months in advance of even trying to get pregnant. With onabotulinum toxin, this one is a little bit more controversial, and you should work with your headache specialist and obstetrician to determine if this is something that everybody feels comfortable continuing. There are some headache specialists that recommend strongly against it, and others would counsel you about the potential for risk, but there's really not a lot of robust safety data out there, such that many people don't feel comfortable continuing onabotulinum toxinate into pregnancy. But the next slide, which is that there are preventive medications for migraine out there that are relatively safe in pregnancy. And so the question to your headache specialist would be, do I need to be on a preventive since migraine might get better during pregnancy? And if so, which one would be more favorable compared with some of the other medications that I just spoke about? So some of those options might include medications like cyproheptadine, verapamil, memantine, some of the nutraceuticals like coenzyme Q10 and riboflavin, along with non-invasive neuromodulation devices, which I spoke about a bit earlier. Just a quick reminder that as you're going through any journey to try to conceive, if your headaches change in any way, you have a change in pattern, you develop new neurologic signs or symptoms such as visual changes, weakness, numbness or tingling, or changes to speech or swallowing, or you develop an unusually severe headache, it's really important to alert your doctor so that they can evaluate for the possibility of another kind of headache rather than migraine. So in summary, just a quick reminder that migraines, again, can improve during pregnancy, which is great news, but not unfortunately for everybody. So it's important that you have a plan in place. Try to talk to your doctor about pregnancy-safe medications and about your current migraine treatment strategy and whether or not that's appropriate in pregnancy. Consider discontinuing those medications that are not safe during pregnancy, and develop a migraine action plan that hopefully you can try out before you get pregnant so you can see if it works well for you. That's all that I have to say, but definitely eager to answer your questions. And thank you so much for the opportunity to speak here today.
Dr. Peretz, thank you so much for sharing that. I have to say, I have just gone through this journey of trying to conceive with migraine, pregnancy with migraine, and then postpartum and breastfeeding with migraine. So I can't stress enough how valuable this information is personally, and I hope our attendees are soaking up the information as well. I think the most important thing that both you and Alicia hit on is talk about a strategy and a plan with your doctor ahead of time. Like, just talk about it now, even if you're not even close to thinking about having a child, talk about it now. I think that's the best. So we really appreciate, especially all the medication, the details. So we really appreciate you taking the time to do this today. All right, and with that, I'd like to introduce our next speaker. I'd like to introduce Dr. Alex Polotsky. He's going to take over. Go ahead and take it away.
Thank you for this introduction, and thank you for dedicating time and effort to have this very important seminar, because we definitely want to make sure that women who are coming to see us for pregnancy and for fertility concerns have appropriate understanding of what could be issues that may prevent successful treatment and a successful course of the other conditions. So Association of Migraine Disorders should really be complimented for dedicating the time to this important topic. So I am a fertility physician here in Denver, Colorado, and my area of expertise is in vitro fertilization. So we'll chat a little bit about some of the details and some of the things that people need to know as they're contemplating optimizing the medical conditions, migraines included, or attacks of migraines included, in preparation for fertility treatments. A very brief overview, and that's important for those of you who may be interested in the scientific data available on migraine attacks in vitro fertilization, is that unfortunately not a lot of information is out there that presents robust data to guide us through the process, and some of it may have to do with how in vitro fertilization has changed. And so on this slide, it's just a brief overview of the two important stages or phases of the IVF process. And the first stage is egg freezing cycle, whether or not the eggs are fertilized. And so the important thing to take away from here is that the vast majority of the time in 2022, during an IVF cycle, a woman is not necessarily getting pregnant right away. And so, which is important to understand and to see that the things that they have available to make sure that your symptoms are well controlled and balanced would be available just like you are preparing for other phases of life, because the actual pregnancy actually happens at the second stage, where you can see the FET process on the bottom of that slide, frozen embryo transfer, and that's typically separated by several weeks. Next slide, please. And so just to see in a little bit more detail, some of the migraine attacks are triggered or could be triggered by changes in your hormones. And a lot of the information out there and the data that's available suggests that when the hormones are suppressed, migraine attacks may be more common or more prevalent. So in this schematic of the IVF cycle, you can see when a typical cycle is being done, and this is just one of the examples, GnRH releasing hormone antagonist, or the protocol that is often used, may give you some of the hormones that are suppressed in the second half of the IVF cycle, leading up to the trigger process, and that could be a period when some people will see more attacks because of the changes in the hormones. However, the attacks, important point here to emphasize is that the attacks might come at any time and will not necessarily be precipitated by hormonal changes. And again, making sure that your symptoms are adequately controlled is really the key in working with your neurology and headache specialists, such as Dr. Peretz or a provider who you may have locally, is super important. And I totally agree with the comments that were used there before. It's very important to have an open channel of communication. And so it's really great to see that the example that was given in the beginning, there's an open channel between the provider of fertility care and neurology and the migraine specialist, so that we can make sure that there's success at the end of this long road. Next slide, please. So unfortunately, a lot of information that's available in the medical literature is really fragmentary. And so the biggest study that was done, I listed here briefly. There was a report from 2005 that looked at the frequency of headaches and migraines attack among people living with migraines. At that point, they indicated that the headaches are more common in people living with migraines, and they did conclude that attacks happen more frequently during a specific phase of the treatment, which is associated with very low levels of estrogen in the blood. The important point to emphasize now is that actually this is a less common method of IVF protocols in 2022. And so we unfortunately don't have up-to-date information that will be relevant for most folks. But it was helpful to know that very low estrogen levels may be correlated with higher levels of attack, which allows for appropriate preparation and anticipation. Next slide, please. So the fertility medications that are being used all unfortunately have ability to increase migraine attacks. And in clinical practice, the way we see that for people coming to our clinic and other clinics is that it's not always predictable based on the biological properties or specific impacts on the hormonal levels for the medications listed. So again, the take-home point from here is that it is important to anticipate and see how migraine attack management and headache management could be regulated with medication that you would use on a regular basis to control and prevent migraines. Next slide, please. We really would need to see that the advocacy that's available from Migraine Disorders Association and other patient advocacy groups and societies could generate more knowledge. There's only one current trial that I saw that was available coming from France. Results of that are not published yet, but hopefully will be published in the near future, that looked at a little bit more numbers, 137 participants, and specifically look at the prevalence of frequency of migraine attacks in women during IVF, and hopefully could provide some answers for people who want to know what to expect. Next slide, please. So the good news is something that I alluded to earlier. Usually during IVF process, especially the first phase, the patient is not pregnant, and the pregnancy could be weeks or even months away. And so, which means that migraine-specific abortive therapy could be safely used, especially because the likelihood of a pregnancy itself at that point would be very low, since the hormones are preventing the pregnancy and more based upon generation of the eggs and creation of embryos. So with that in mind, I welcome any and all questions, and definitely want to make sure that doctors and providers from a variety of specialties could be utilized by patients to make sure that you get appropriate care for fertility and on your road to successful pregnancy, and also making sure that this road could be less bumpy. That's all I have.
Thank you, Dr. Polotsky, for bringing some really incredible information on IVF and migraine. We really appreciate the time. It's so interesting to hear some of the data that's collected and to know some of the risk, the potential risk for migraine and IVF, but also to kind of put things in perspective. You did at the end that the good news is that, you know, if you're doing IVF treatment, you're not pregnant right away, so you can still have options to treat migraine. So it's really good to get that into perspective as well. So thank you so much for sharing with us. All right, now we're going to move on to our question and answer period. Thank you to all of our panelists for joining us and to our attendees for joining us. We really appreciate it. Before we jump over to the Q&As, again, you can see on your screen that there's a question right there. So you can go ahead and check out some of our other resources that the Association of Migraine Disorder has on this topic and other topics as well. And if you do have questions, please feel free to put them over into the Q&A box. And if for some reason we don't get to them or we're not able to answer them here, we will do our best to get those questions answered for you and shoot you an email or something like that. That also being said, you can find a lot more information and we can get your questions answered if you sign up for our newsletter. So we will put a link in the chat box if you want to sign up for our newsletter as well. All right, so let's jump into our question and answer period. The first question is, and I feel like any of you can answer these. Is it possible to get pregnant while on medication? I will say, is that preventative medication, abortive medication, or is that even medication for other conditions that one might have?
I don't know if you want me to jump in here.
Go for it.
I would say, yes, it's possible to get pregnant on any migraine medication that you're on, which is why I think it's good to kind of meet with your obstetrician and headache specialist in advance to make sure that if you are on a medication such as topiramate, which is a preventive medication, and that's not so safe in pregnancy, that you go off of it before you're starting to try to get pregnant. But yes, you can still get pregnant while on topiramate. And to my knowledge, while you're on any of the medications we traditionally use for migraine, it's just not necessarily safe for baby.
Yeah. I would definitely agree with Dr. Peretz. It is important to anticipate when that time in your life comes, and hopefully you don't need to see one of the folks who are my kind of a physician with my specialty, but if you do, that's okay. We love everyone coming to our door. Sometimes people come in anticipation of trying to conceive, but it is important to make sure that once you do get pregnant, you use medications that are considered to be safe, and it's great to have a variety of different options, and making sure that you speak with a migraine doctor will be very, very important.
Great. Thank you all for answering that. The next question, I believe this could go to Dr. Peretz or to Alicia. What kind of physical therapy would be appropriate in this? Head and neck? Alicia, I'm not sure if you talked about physical therapy or not, but I know that it is a thing for some people who have dizziness.
Yeah, so I'm not sure what the question is pertaining, like if you're talking about like head and neck tension, that is something that I experience, and you can definitely treat. Like what I usually do is I see someone regularly for acupressure and also massage therapy. You just have to be careful in your first trimester with massage therapy, and sometimes therapists won't even work on you during that stage. I think your RE may even have rules on it as well, so that's just something you have to check with them. As far as like physical therapy, or if you're doing vestibular therapy, all of that should be fine, but just be aware, like I know for me it triggers a lot of dizziness or sometimes nausea, and if you're already feeling nauseous while pregnant, that could cause some issues, especially if you're off balance. That's another thing that they probably don't want you to do. I know that I personally had to take some time off from exercise and everything like that because of the risk of falling. So if you do experience vestibular migraine, that's something to watch for as well.
Great. Thank you for that. Dr. Peretz, do you want to jump in?
Yeah, I think, with physical therapy, I would focus on head and neck, right? The muscles of the neck and the head, making sure that you have a good ergonomic situation if you're at a desk all day, because these things can be helpful. And, our bodies change during the course of pregnancy. So having a physical therapist involved to kind of help with that. With vestibular migraine, sometimes vestibular therapy can be helpful, but to Alicia's point, sometimes it made her symptoms a little bit worse. So you just have to be careful about that as well.
Great. Thank you for that. Jocelyn wants to know, where do oral anti-CGRPs fall into this category, which I think we're talking to you, Dr. Peretz, when you mentioned the injectables, and then you talked about some of the CGRPs, if you want to just kind of chime in on that, if it's safe during preconception and if they are safe during pregnancy.
Yeah, so I think, the jury's still out in terms of whether or not they're safe during pregnancy. I have my theoretical concerns about CGRP blockade in pregnancy because of the increased risk for preeclampsia with abnormal levels of CGRP in animal models. So what I would probably say is the oral anti-CGRP agents have a shorter half-life. And so you can kind of control how much is in your system because you're taking it orally. You can stop it at any point. So maybe it's safer in the first half of your menstrual cycle when you're not pregnant. And then once you are pregnant, I'd probably be more cautious with it. There will be probably more real world data coming out and registry data. So we'll understand more what the true risks are with it. But at this point, I would advise my patients to avoid the injectable CGRP agents, and then with the oral agents, just to be cautious around their use.
Great, thank you for that. And a follow-up question, I think this will go to you, Dr. Polotsky. Is there any link for CGRP in the development of healthy eggs, the stages before starting the IVF medications and during stimulation meds?
Yeah, no, it's a good question, but most medications that are out there that are used for women trying to conceive, the information is really not available for the impact specifically on the egg function. Most of the information that we have that could relate to potentially teratogenic effects or effects on the pregnancy is really based on the influence on the pregnancy itself once somebody gets pregnant. So the vast majority of the time when something is being used, when people are, let's say, doing an egg freezing only, let's say somebody is looking to do egg freezing, we don't have much data available, much guidance. So even medications that are known to be teratogenic are often used in the process of egg freezing. And I agree with Dr. Peretz. I think the jury is still out, but at the same time, most experts would suggest that it's not appropriate to withdraw something that is potentially highly relevant for the quality of life if the data is not there. So most people would not be overly restrictive when you are not trying to imminently get pregnant. And like I mentioned a little bit earlier, perhaps a little bit paradoxically, you are not pregnant during IVF. We know that. So it may be the safest time to use these medications to make sure you're comfortable.
Great, thank you all. Our next question is from Ashley. They are currently taking topiramate or Topamax, and we know that's not safe for pregnancy. And they're looking for, again, this is not necessarily medical advice, but what could be some options for people who want to take medication through pregnancy? Are there some safe options that we might just want to touch on again? Dr. Peretz?
Yeah, so I think this is kind of a challenging one because we know that preventive medication can take a while to start working as well. So that's a consideration of kind of tapering off of the Topamax and maybe having something else in place. And one thing to kind of think about is, do you need a preventive medication at this stage? Sometimes things have gotten better to the point that you may not need a preventive medication. And we know, again, that migraines can improve during the course of pregnancy. So maybe, you would need a preventive medication for a period of time, but could discontinue it later. In terms of some medications to consider for prevention, the neuromodulatory devices are interesting options to consider for both prevention and acute use. There are also medications like cyproheptadine, verapamil, memantine, some of the ones that I mentioned earlier, which have fairly okay data in terms of migraine prevention. There are some nutraceuticals like coenzyme Q10 and riboflavin, which are also interesting ones to think about. But I do agree that I would taper off of topiramate before you start trying to conceive, because we don't know how fast you'll conceive, and it's not the best medication to be on during the course of a pregnancy.
I thought I'd just jump in here with a little bit of my story. So what was approved for me to take was the timolol eye drops. And what was really nice about those is I could use them as an acute treatment, and they were also my preventative treatment. So that's something to ask your doctor about because it is a beta blocker. So that could be an option. And I'm also having a lot of success with GammaCore postpartum, especially during breastfeeding. So that was a big win for me to find when I was looking for things to use breastfeeding. And so it's nice to hear it's also okay during pregnancy, because that's what I plan to do next time.
I think beta blockers are a great option as well. It's something that you should definitely talk to the obstetrician about to monitor over the course of pregnancy, if you do continue beta blockers into pregnancy. And yeah, devices are they're interesting options, and they're really, I think they have a lot of potential promise during pregnancy.
Wonderful. We'll take one last call for questions if anyone has any. And I'd like to just say a big thank you to our panelists and to all of you who have participated and watched. We really appreciate it. I do want to just mention that Dr. Peretz said, there are registries out there. I think for me, one of the most frustrating things is there just isn't a lot of data and not a lot of research for women trying to conceive with migraine, and then people who are pregnant and have migraine, because there isn't a lot of research on it. So it's frustrating. So we really appreciate the information. And if you are interested, there are some pharmaceutical companies that are running registries for newer medications to try to capture the use or capture data during the use of pregnancy. So if you are interested in getting more information on that or participating, possibly signing up for a registry, we will go ahead and put links to those registries in a follow-up email after this webinar. So just wanted to throw that out there. And looks like we are all done with the questions. We really appreciate you joining us, and just want to send a reminder that this was just the first webinar in our series of 3 on the connection of migraine and pregnancy. May 25th, we'll be talking about migraine during pregnancy, including treatments, common pregnancy concerns, and comorbidities. Dr. Ashley Holdridge will be joining us, and Dr. Merle Diamond. I will also be sharing my story, which I look forward to doing that with all of you. And then we have another webinar on May 31st. It will go over everything you need to know postpartum. That includes breastfeeding and migraine. And we will hear from Dr. Megan Donnelly and Marina Medved from Parenting with Migraine blog. So again, thank you all so much for joining us. To our panelists, we really appreciate you taking the time and sharing your stories and giving us worthwhile information. I know that I really soaked it up. To all of our participants, thank you so much for joining us. And you can go ahead and sign up for our newsletter or find more information over at the Association of Migraine Disorders website at migrainedisorders.org. Thanks again so much for joining us. I'm Molly O'Brien. I hope to see you at our upcoming webinars. Take care.